give the synovial fluid, which is be lubricating the tendon. Okay, so this distal bicep tendon does not have any synovial sheath, but it has got a paratenon. What is paratenon? Paratenon is simply a connective tissue layer. Okay, it is not like the synovial sheath, and you have this paratenon here in distal biceps tendon as well as in Achilles tendon. Fine. So this was out of the syllabus, but still you should keep in your mind. So one muscle is your brachialis, other muscle is your biceps, but what is more important to us in this area is your distal distal tendon of this biceps muscle. Okay, so now you should remember these two very very important things about the biceps muscle. Okay, biceps action is basically positional. Okay, how you have kept your elbow. So if you have kept your elbow extended, in that condition biceps is the flexor. Okay, and when you have flexed your elbow, it is the supinator. Fine, remember this, it is very very important when I'll be discussing the pathologies. So that time you should remember this thing. Fine, moving to the next muscle, that is the brachialis. Now, what you have to remember about the brachialis, that this is the strongest flexor of the elbow joint. So this basically is also known as the workhorse of the elbow joint. Okay, and it is, as a flexor, it is more superior to your biceps, right? Then what I was telling you, that this is the biceps tendon. We have seen in the previous slides that this gets inserted on the radial tuberosity. So since it does not have a synovial sheath which is going to protect this tendon when it is rubbing against the radial tuberosity, so you have a bursa. Okay, here this is known as bicipito-radial bursa. The significance of this bursa is whenever you have an inflammation in this tendon, you have a reactivity response, inside this bursa. So you have the collection of fluid, okay, and you have the enlargement of this bursa. Fine. Then if you go to the medial aspect, you have the common flexors origin. Fine. And beneath, and if you go to the lateral aspect, you have the common extensor origin. Fine. This is how the olecranon fossa looks from the back, and this is the olecranon process which get inserted into this olecranon fossa. Fine. So posteriorly, now it is covered by, this is the tendon of your triceps. Okay, triceps has got long head which is on the medial aspect, then lateral head on the lateral aspect, and beneath these two you have the medial head. Three of them, they combine to form a tendon, and it inserts on the distal portion of this olecranon process. Fine. So one bursa we have discussed, that was the bicipito-radial bursa. The second bursa is this one. Okay, subcutaneous olecranon bursa. So subcutaneous means it should be between the skin and the second thing. So the skin and the second thing is your olecranon process. So in between these two, you have a bursa, and this is known as subcutaneous bursa. In some of the books, you see a bursa name as subtendinous olecranon bursa. Do not get confused with that, because that bursa is between this triceps tendon and your olecranon process. Okay. So when we are talking about the range of motion, the flexion of the elbow, we have three range of motions. Okay, we have flexion, we have extension, and then supination and pronation. So when I want to test the flexion, you can just simply ask the patient to touch, the shoulder with his this fingers. Okay, if he's able to do so, the flexion is perfect. Okay, extension is 0 degree. Just ask him to straighten this hand fully. So that is extension, and it is 0 degree. This is the elbow joint. So this is the pronation. Okay, and this is the supination. What you need to remember is when we are talking about the pronation, okay, the radius will come over the ulna. Okay, and when we are talking about the supination, both of them, they are lying side by side. Okay, this is important, because what will happen, we are going to discuss certain conditions in which they are going to get aggravated when we are doing the pronation. Why? Because you have the bursa here. Okay, so if somebody is doing the pronation, uh, like involved in certain works in which the pronation continuously they have to just pronate their forearm. So what is going to happen, you have the impingement of this bursa and the distal tendon, distal biceps tendon. So remember this, that's the reason this slide is very, very important, that what exactly will be the movement of the radius when we are doing the pronation and what exactly will be the movement when we are doing supination. Fine. Okay, so this was all about the anatomy. Now a patient has come to you with elbow pain. Okay, so elbow pain, the first thing, you should just ask the patient whether he had any history of trauma. Okay, because trauma, tumor, 2 2, okay, 2T, and then your infection, okay, this comes in your red flags. Okay, so if the patient says suddenly this elbow has swollen up like this, okay, and I'm feeling very feverish since then, think of some infection. So infection, then a previous history of any malignancy, loss of weight, loss of appetite, all those things. So that is also a red flag. Trauma is a red flag. Infection is a red flag. And compartment syndrome, had a plaster and suddenly the contractions of the hand, and also all those things are red flags. Red flags requires immediate investigations, immediate management. So you should send the patient to an orthopedic surgeon. Okay, I think that is the best thing you can do. And the second step is, now you have found out that now the patient is not like the patient is not giving any history of any trauma. Okay, then you should find out whether it's a local pain or whether it is like coming from somewhere else to the elbow. From where it can come from the shoulder, okay, or either it can come from the neck. So if the patient is giving, you are keep on asking the history, the patient says no, my pain is starting from here and then it is coming up to the elbow, or if the patient says my pain is here and now it is coming to the elbow, so that is like referred pain from the above structure, okay, not from the elbow itself. So today we are going to discuss the causes which are specific to the elbow. Okay, so referred causes I'm not discussing because you would have had your shoulder class and you would have had your neck class, so I'm not going to go into the detail about it. So just remember, when a patient comes to history, this is very, very important. First ask them whether there was any history of trauma. Okay, after that the patient developed the pain, whether there is any fever. Okay, right now if the patient is having, then whether the pain is confined to the elbow or it is coming from up. Okay, once you have done this, so we will come to the elbow. Now what was the point of showing you the anatomy slide is that now you know what all are the structures we are going to look at and what are actually are the pain generators there, right? So we have talked about the joint. So joint, you can have either an inflammatory arthropathy or you can have an osteoarthritis, right? Then we have talked about the bursa. So bursa, you can have bursitis. We have talked about the tendon. So tendon, you can have tendinopathy. Okay, do not use this term tendinitis no more, because it's a tendinopathy. And if you have an inflammation of the synovial sheath, we call it as tenosynovitis. If you have the structural changes inside the tendon, we call it as tendinosis. Fine. Then we have seen ligaments. So some problem with the ligaments we are going to learn today, and something about the nerves, because we have seen that, elbow, you have the ulnar nerve which is crossing, radial nerve which is crossing, and the median nerve which is crossing. So we are going to now find out from where all we can get pain in the elbow joint. Fine. Okay, so if a patient, before going into that, if a patient who has come to you with pain, always remember these points, and they are not only for the elbow pain, they are for pain anywhere in the body. Okay, ask the patient about the onset, whether it was a sudden onset or whether it is gradual. Gradual is going to tell you something about the degenerative thing. Okay, location, whether it is specifically to one point or it is diffuse. Okay, what activities basically aggravates the pain, what relieves the pain, and whether there is any radiation of the pain is present continuously or whether it is more in the day or in the night. Okay, so now we'll be seeing the conditions and then we will be coming back to this slide, right? Okay. Always remember that you need to have a detailed, past history. Give, some time to this history also, because why is it important? Supposedly you have asked, the patient said, no, I recently, like, there is no history of any trauma recently, but long back, like approximately 3 months ago, I had fallen down, and then I got some surgery done in my elbow. Okay, some plating or something like that. So why is it important? Because if you have a surgery, if the nerves are passing by, you can have the entrapment neuropathies there, right? So this is also very, very important, right? Second thing, diabetic hypothyroidism, all these conditions, the tunnel syndromes are more. Okay, so this you need to ask. Second thing, whether the patient had similar episodes in the past. It means, it is I always say to my patient that your pain is like a tree. If you cut it from above, it means you are just giving some painkillers and you're treating the roots. If you treat the roots, your tree will you won't get the tree again. So similar episodes in the past, how long they had been, whether the patient had taken any treatment for that. Or because sometimes what happens, the patient usually don't go to a doctor also, they just go to a pharmacist, they buy some drugs, and they just take, I think that resolves their pain and they are happy with it. Okay, so do ask this history from the patient. Then occupation is very, very important when we are talking about the elbow and the wrist pain, wrist and hand pain. Very, very important. Ask the patient about the occupation, and today we are going to learn lots and lots of occupation and what exactly are the causes which are very specific in that particular occupation. Okay, family history, as you know, RA runs in families, so that gives us a very good clue. Sleep, because like a patient who is having carpal tunnel syndrome, okay, many of the times he's going to have night pain, because when you sleep you flex your, this wrist like this, so you have the compression of the nerve, edema, and then pain. So this is very important. Ask whether the patient is able to sleep properly in the night, or he or she gets up in between, right? So, with that history, with that anatomy at the back of our mind, we are going to now classify the elbow pain into four categories. One is your anterior, medial, lateral, and posterior. Fine. So, what we have learned from our anatomy slide, that in the anterior aspect, it is the biceps tendon, which is very important. Okay. So, if there is a tendon, you can have tendinosis, you can have partial tear, and you can have rupture. So, how this happens, we will learn about it, and then we'll go into the clinical history of that. Okay, so see, this tendon has got an hypovascular area which is approximately 10 millimeter above its insertion. So what happens, what I was telling you, a patient who is repeatedly involved in pronation activity. Okay, so if that person is repeatedly involved in any pronation activity, so what happens? You have the impingement of this tendon. Impingement of this tendons means repeated micro traumas will develop inside the tendon. Sometimes the tendon heals over a period of time. Otherwise, if the tendon is not able to heal, the degenerative process it sets in. Okay, and the failure of healing is gonna lead into your tendinosis, then your partial tear, and then your complete tear. Fine. So this is how a healthy tendon looks like. And if you have the repeated microtraumas, you can have angiofibroblastic hyperplasia, apoptosis, breakdown of collagen. Why this is important? It is because a patient who is continuously involved in chronic repetitive activity, okay, so what happens, ultimately the tendon is going to be weak, and sometimes, and maybe in, a short span of time, he may present to you with a rupture, right? So if you have assisted before, you can just help the patient to slow down that, right? You can help the patient heal his or her tendon. Fine. But if there is why exactly will be the pain in these conditions, right? When you have a degenerative process which sets in, it's because the nerves, they also grow there, and they release all the excitatory neurotransmitters, and which are responsible for causing the pain in that particular area. Okay, so biceps tendon, uh, who all are the individuals who are very much prone where you can get the inflammation of this tendon? Okay, remember, there's a male, more than 40 years of age, okay, smokers, weightlifters, manual laborers, and gymnastics. Okay, so these are the people who are at high risk of developing the inflammation of the distal tendon. Fine. So if the tendon is, inflamed, tendinosis has set in. Now the patient is almost having little partial tear, and suddenly this weightlifter has one day gone to the gym and he was trying to lift the weight, and suddenly he is having excruciating pain, okay, in the anterior aspect of the elbow, in the cubital fossa, and suddenly he will see the retracted portion of the muscle, a bulge here. So what happens there? Because the tendon was weak, now it has ruptured, right? And this muscle is going to retract, it will go back, and it will form a deformity here, right? And if you examine this patient, if it happens to visit you and you examine this patient, what you will see, the patient will not be able to supinate, okay, the elbow, but flexion will be preserved. And all of you, if you can flex your elbow, if I'm able to show you, if you flex your elbow and you try to hook, the biceps tendon with your index finger, you will be able to do so. But if there is a rupture, you won't be able to do so, and this test is known as hook test. Fine. So if it is an acute stage, pain is going to be excruciating, okay, you will be having a lump here because the muscle would have got retracted proximally. But if it's a chronic condition, means still the tendinosis is going on, the patient is going to have localized pain. If you try to press the distal tendon, this is going to be painful. Hook test is going to be positive, is going to be negative here. And if you try to supinate the elbow, if you try to supinate your forearm and you try to flex the elbow joint, this is going to be painful. But remember, you need to do the flexion in the extended position and supination in the flexed position. Fine. So that was all about the biceps tendon, inflammation of the biceps tendon and its clinical presentation. Coming to the bicipitoradial bursitis, what I have told you previously also, that the tendon, when it is getting attached to the radial tuberosity, you have a bursa over there, right? So if there is a reactive changes in that bursa because of that inflamed tendon, so this bursa is going to get inflamed, okay? And if you just ignore it, then what happens? The bursal layers, they are going to get fibrosed. This is going to present like a lump, like this, okay, on the anterior aspect. You might be thinking it could be something or other, it could be a lipoma, something. But if you are doing matlab USG, then you will be able to see the distal tendon fully, and edematous, and the echogenicity, everything is lost. So if a patient, the gist of this is that if a patient comes to you with a swelling over the anterior elbow, do not think it to be a lipoma or something else. Keep in your mind that it could be a bicipitoradial bursitis. Fine. Then coming to the medial elbow. Medial elbow, I'm going to talk about three things: medial epicondylitis, medial collateral ligament, and cubital tunnel syndrome. So when we are talking about this golfer's elbow, we say it's a chronic tendinosis of the flexor pronator musculature, insertion on the medial epicondyle of the humerus as a result of overuse and repetitive stress. I'm not saying it to be a medial epicondylitis because there are papers which shows that the histological studies have been done and they have failed to show the inflammatory cells in the affected tissue. So the inflammatory process is not there, so it is better to call it as elbow tendinosis, because again, what I have explained you in the biceps tendinosis slide, that it is the degenerative one, okay, not the inflammatory one. So it's better to call it as medial elbow tendinosis. This is what I have already explained. So now you see, we call it as golfer's elbow. Okay, so it is not only seen in the sports person who are playing golf, but you can see it in ample amount of sports. I have just shown few, and also in various other occupations like plumber, carpenter, your construction workers. Fine. Here the patient is going to give you a history where he's going to have pain over the medial epicondyle. The grasping of something is going to be very painful. Okay, throwing is also going to be very painful. So these are the history which he will give you. And if you put your thumb over your medial epicondyle, it is going to be very anterior, or over it, then it is going to be very painful. And see, this is how you should hold the forearm. And with one hand, you ask the patient to flex, okay, fully flex his forearm, and then you try to extend it and ask the patient to keep it flexed. Then it is going to be this lateral epicondyle, this area, sorry, medial epicondyle, this area is going to be painful. Fine. Mostly it is a clinical diagnosis. The patient comes to you with a lateral with a medial elbow pain. There is no role of radiography here, but US is very, very important. If you know how to just put a probe and look at this tendon, then the diagnosis is superlated by your findings. Like your clinical diagnosis is going to be perfectly all right if you have got an ultrasound with you where you can look at this tendon. This tendon appears fibrillar, and if there is some tendinosis, this is going to become black. Partial tear also you can make out, and complete tear also you can make out. And I'll be showing this in my lateral elbow slides. Okay, so skipping this for the time being. Then first thing we have now, if there is a problem with the common flexor tendon, we know there was a pain at the medial epicondyle. This tenderness was there, pain was there, tenderness was there, and then when you have tried to examine the flexion against resistance, you found it, this area was painful. Supposedly nothing like pain is there, but you have given all the conservative treatment, still the patient is having pain. Think of a medial collateral ligament injury that time. Okay, so medial collateral ligament injury, I'll be discussing the lateral also here itself. So just look at the slide very carefully. Okay, so if you want to test the medial epicondyle, medial collateral ligament. So medial collateral ligament is from your medial epicondyle to your ulnar, and it is a triangular structure. Okay, the anterior is the strongest one, they say. So what you are supposed to do, you are supposed to, if this is my uh, medial side, so you are supposed to stress this side. Okay, how I will be able to stress it? I will just put my pressure from here to this side, right? So you need to stress this side, and then you need to hold your forearm and just bring, just pull it away from your body. So that's why the valgus test is for your medial collateral ligament. Supposedly you're fortunate enough to have an ultrasound with you, you can see that supposedly these are the two joint lines. Okay, and your medial collateral ligament is holding it. So when you are just trying to pull your forearm away, you will see that the joint space, it decreases. But if there is an injury, you have the widening of this joint space. So you can do a dynamic assessment. When you have an ultrasound, you can put the ultrasound, you can look at this. Otherwise, if you don't have an ultrasound, clinically you want to see, you will be able to see that give way, laxicity in that area. Okay, if you are pressing it and you're trying to pull your forearm away from the body, this side is going to be lax, as if simply you can just move it like without any resistance. The same thing, you need to bring your forearm towards your body, you need to stress it from this side to this side if you want to look for the lateral collateral ligament. So coming to the cubital tunnel, when we are talking about the cubital tunnel, this is our medial epicondyle, this is our ulnar process, okay, olecranon process of the ulna. So now you see in between these two, the ulnar nerve, it passes. So there is a fibrous band like thing which is connecting the medial epicondyle to this olecranon process. Okay, and this, okay, is also known as Osborne. Some says it's Osborne fascia, some says it is retinaculum. You remember it like, it is just a fibrous sheet. Whatsoever name you want to remember, you can do so. And after passing through that, so it was like two bony thing like this, and now you have covered it like this. So from there, the ulnar nerve, it passes out and it passes through, and then it enters the two head of your flexor carpi ulnaris. Okay, flexor carpi ulnaris, two heads also, you have the aponeurotic, joining of these two heads. So it passes then from there, and then it goes and supplies, goes and enters the Guyane canals and supply your hand. Okay, in between it gives branches to your forearm muscles, and of course it gives lots and lots of branches in your wrist. So if this ulnar nerve get entrapped in this osteofibrous tunnel, we call it as cubital tunnel syndrome. Okay, so you know that ulnar nerve has got a palmar cutaneous branch and a dorsal cutaneous branch. Okay, these are the sensory branches. So it supplies the palmar 1.5 fingers, and of course the dorsal 1.5 fingers. Fine. Now, why exactly the patient should of the cubital tunnel syndrome should get pain? Okay, so what happens when you extend your elbow? This tunnel, it becomes roomiest. Okay, it is circular and it becomes like this. Okay, but when I'm trying to flex, what I'm doing is I am increasing the distance between my medial epicondyle and my olecranon process. So the aponeurosis, it becomes tightened and it compresses the nerve against the medial epicondyle, right? So this is how the cubital tunnel syndrome, the pathology of the cubital tunnel syndrome is because of the compression of this ulnar nerve against the medial epicondyle. But there are various causes for it. Okay, you can have an accessory anconeus muscle. Sometimes the band is very very thick. Okay, so it will be compressing it, but there are certain positions also which makes you prone to the development of this cubital tunnel syndrome. Like a person who is sitting like this, he is always flexing. Okay, so he's always just keeping his hand like this. So it means you are just trying to compress your ulnar nerve, okay, most of the time. And then if a patient is trying to keep the forearm in the pronated position, that time also you will be compressing this ulnar nerve. And all this is not for a short span of time, but you are repeatedly doing it, results in the entrapment. So if there is an entrapment of your ulnar nerve, the patient is going to have pain from here in the distribution of your ulnar nerve. So then you need to remember what all ulnar nerve it supplies. So ulnar nerve supplies your flexor carpi ulnaris. So this is gone, okay, because it is compressed here. It is not able to give motor supply to this muscle. So what will happen? The flexor carpi radialis will become overactive, and you will have a deviation of your wrist towards this radial side. Okay. Ulnar nerve supplies the palmar interosseous and the dorsal interosseous. Okay, palmar is adduction and dorsal is abduction. How you can remember when you want to slap someone, all your fingers should be, together. Okay, so palmar interosseous is adduction, and then dorsal is abduction. So if you're not able to do so, the fingers are going to be like this. Okay, then lumbricals, last two, they are supplied by ulnar nerve. Always remember the function of lumbricals like this. Okay, this is L. So lumbricals causes your flexion of your metacarpal joint and extension of your interphalangeal joint. So if there is a problem with your lumbricals, opposite will happen. Okay. Then there is something called as Froment's sign, okay, which is going to be positive. So what will happen? What is this Froment sign? Is when you asked this, when I'm talking about the thumb, in the horizontal plane is my flexion, extension. In my vertical plane is my abduction and adduction. Okay, so adductor pollicis is supplied by ulnar nerve. So if I want to hold something, if I want to adduct my thumb, I need to have my ulnar nerve, which is working very nicely, right? So if I'll give a paper to a patient and I'll ask the patient to hold that paper because that adductor pollicis is not working, what he will do, he will try to use his flexor pollicis longus. Flexor pollicis longus is supplied by your anterior interosseous nerve. Okay, so he will try to use that muscle so that he will be able to hold it. That's why, the picture is like this. So that was all about the medial elbow pain. So medial elbow, we have talked about the common flexor tendon. We have talked about the medial collateral ligament, and then we have talked about the cubital tunnel syndrome. Cubital tunnel syndrome, because it's a nerve, so you have the sensory things. You have the numbness, tingling sensation, then hyperesthesia in the direction of the ulnar nerve, with some of the things which I have shown you. Then your medial collateral ligament, you should think of its injury if like clinically, if you have a US, you can just differentiate between whether it is a problem with the tendon or whether it is a problem with the ligament. But if you don't have that clinically, uh, usually medial, the common flexor tendon, you have a tenderness at the medial epicondyle. Then flexion of the wrist against resistance is going to be painful, and it is going to be the medial epicondyle on or anterior is going to be tender. Fine. Collateral ligament, the valgus test is going to be positive. So that was the gist of the medial elbow pain. Now we'll come to the lateral elbow pain. Okay, so lateral, again, you have a common extensor tendon, you have a collateral ligament, but there is something new. There it was cubital tunnel, and this side you have the radial tunnel. Okay, so radial tunnel, you basically, the radial nerve, it divides into two division, that is superficial and deep. Okay, so the involvement of the deep branch is known as radial tunnel syndrome, but today you will see that it is no more called as radial tunnel syndrome. Okay, so it is the entrapment of the deep branch of the radial nerve, and we will be discussing in our subsequent slides. So again, tennis elbow, like medial side, it was called as golfer's elbow. So lateral side, it is known as tennis elbow. But again, if you see the literature, it is again a misnomer, because you don't see this condition only in the like sports persons who play tennis, but you can see it in enormous amount of sports. Okay, even in like people who play golfs, they also get this tennis elbow. Okay, so again, this lateral epicondylitis is a misnomer. We should not be using it because there was no inflammatory cells in the affected tissue. So again, better to call it as lateral elbow tendinosis. This is just a repetition. Okay, medial, you make it lateral now. Okay, so this is more common in individuals who are involved in hand grasping activities or high torque wrist turning activities, like when you have to scoop the ice cream. Okay, and tennis player, as the name was there. Okay, again, the pain is going to be over the lateral epicondyle. Patient is going to find it difficult to hold the cup of tea or the hammer. Okay, like supposedly whatever activity he is doing like this, okay, it's going to be painful. Their throwing activity was painful. Okay, then if you press it or press over the lateral epicondyle, it is going to be very painful. Again, if you want to check the grip, this is going to be again painful. Okay, but remember one thing, the flexion and the extension at the elbow is going to be normal, because we have learned that flexion is by brachialis and biceps, and your extension is by triceps. So we don't have any problem in these two muscles. So this elbow joint movement is going to be, the flexion and extension is going to be normal. Okay, sometimes the patient may complain. It is not many times seen, like when you are pronating, that time also the patient is going to complain of pain. So that can be there, but flexion and extension is going to be perfectly all right. Okay, then again, you ask the patient to extend, and then you try to flex the wrist joint. So again, the patient is going to complain of pain over the lateral epicondyle. Okay, so mostly the diagnosis is clinical, and radiography has got a vital role. And if you have got a US, you are, I think, blessed. So you can do a diagnosis and you can go for a therapeutic thing also. So this is how the tendon looks like, okay, in the ultrasound fibrillar pattern. And if you have a tendinosis, this is how the tendon is going to look like. You can make out even the partial tear, and you can make out even the complete tear. Fine. And you can even make out the calcific deposits in the tendon. So the same thing you can do for the common flexor tendon, right? The same pattern will be there in case of common flexor tendon also. So we have talked about the valgus test for the medial collateral ligament, and varus test is for the lateral collateral ligament. I'm not repeating it again. Now coming to the radial nerve, when you have the entrapment of the deep branch of the radial nerve, you can have two presentation. One is pins, one is RTS. Okay. So first, just understand the little bit anatomy of the radial nerve. So this is the radial nerve. Okay, this is the radial head. It divides into superficial and the deep branch. Now, this superficial branch is purely sensory. Okay, and this deep branch is purely a motor branch. Fine. This sensory branch, the superficial branch, it passes below the brachial radialis. Okay, and this deep branch, it passes between the two heads of the supinator, as you can see in this picture. Okay, this is the superficial head, this is the deep head, and it passes between these two, and then it enters our posterior aspect of our forearm. Fine. So this is how the supinator, the proximal portion, which looks like, it is also known as arcade of Frosse. Okay, and this is the distal portion. Fine. So you can have the compression of this nerve at various sites. You can have it at the radial head. We have learned that at the radial head, it divides into a superficial and the deep branch. Okay, at the radial neck, where you can have the radial recurrent vessels, you can have the compression because of the tendinous margin of your extensor carpi radialis. Sometimes you have a free aponeurotic margin of supinator, or sometimes at the distal edge of supinator. If you can remember these four, well and good. If you don't remember, if you know the clinical things, clinical findings, you will be able to make out the entrapment. So first we will learn how to diagnose this. Okay, so recent if you see the recent literature, they say that we should call it as entrapment of the deep branch of radial nerve. We should not be calling it as radial tunnel syndrome. Okay, because radial tunnel syndrome, the researchers, they have found that it is a kind of stress injury. Okay, repetitive pronation movement. Okay, repetitive movements of your radial head against the ulnar against the ulna will result in a kind of a syndrome, and which is known as radial tunnel syndrome. But when we are talking about the posterior interosseous nerve syndrome, this is basically a palsy. Okay, you have because this nerve, it supplies everything, all the extensors of our forearm except the extensor carpi radialis longus. Okay, because that is given off by the main radial branch. Okay, so this basically supplies all the extensors. So if this nerve is involved, you will be having a problem with all the extensors muscles of the forearm. But in the radial tunnel syndrome, you won't be having something like that. So the patient is going to have pain. Okay, and this pain is going to be proximally 3 to 6 centimeter from your radial head. How you can palpate the radial head is, you should know where is your lateral epicondyle. If you keep on moving your finger down, so that is a depression like thing, so that is your radial head. So approximately 3 to 4 centimeter distal to the lateral epicondyle, the patient is going to complain of pain. Okay, here if you try to test the extension, okay, of the wrist, yes, the extension might be weak. Okay, it could be because of uh, pain there. Okay, so it is not an absolute weakness, it is a relative weakness. Okay, but if you see pins, what the patient will come with? Finger drop. Okay, so finger drop means the posterior androgeus nerve is involved. Okay, the second thing, okay, if posterior androgeus nerve is involved, what will happen? If you will the patient will have this deviation of the wrist towards the radial direction. Why? Because extensor carpi radialis longus, the branch from the radial nerve, is given over the radial tunnel. Okay, and so even if the patient is able to so this extensor carpi ulnaris is weak because it is supplied by posterior androgeus nerve, and you have a problem with the posterior androgeus nerve, so this muscle is not gonna work, and this muscle is working, so you will be having a deviation of your wrist towards the radial side, and you will not be able to extend the finger of this patient. But all these things will not be there if there is a radial tunnel syndrome. Okay, there won't be any finger drop. And remember, this is very important for us to find out that 3.5 centimeter distal to the radial head, okay, it divides and it emerges as PIN 7.5 centimeter distal to the radial head. Maybe clinically it won't be that useful, but if you want to look for the entrapment of this, exactly if you put your probe, you will be able to see the pin at this site. Okay. Then I have already discussed this. Okay, so this question might come to your mind that, when it is a pure motor nerve, why the patient is going to have pain. So again, there was a study which was done that this nerve, it contains C fibers. So they are carrying the nociceptive inputs to the spinal cord from the structures in the forearm. And if you want to read, you can take a screenshot and you can read further about it. Okay. So radial tunnel syndrome is different. So do not intermingle radial tunnel syndrome and posterior androgeus syndrome together. So deep nerve entrapment, you can have a presentation like radial tunnel syndrome, you can have a presentation of pins. Since the causes for both these two remains the same, so still some people, they believe that they are no two different entity, they are one. But if you clinically examine the patient, you will come to know that they are no more the same entity, they are different ones. Fine. Okay, so that was about the deep branch. If you have the entrapment of your superficial branch, we have learned that the superficial branch, it descends beneath the brachioradialis. So this branch, approximately at a distance of 7 to 9 centimeter from the radial styloid process, it becomes superficial. Okay, and at this position, the brachioradialis and the extensor carpi radialis, they lie like this. Okay, and from here in between the this nerve is gonna come out. So supposedly, if a patient who is continuously involving in the pronation, okay, continuously involving in the pronation activity, then what will happen? I think I can show you. Okay, so what happens then? This is the ECRL tendon. It crosses deep to the brachioradialis. So this will be like this. Okay. So the nerve is, these are the two tendons. The nerve is coming like this. So if they are overlapping upon each other, they are going to compress this nerve, right? If you are going to compress this nerve, what will happen? The patient is going to have problem in this area, because the radial, this sensory superficial branch of the radial nerve, it supplies this area. So what exactly will be the presentation of the patient is going to have pain in this whole area. Okay, you can have numbness because it's a sensory nerve. You can have numbness, you can have increased sensitivity of pain. So that is hyperalgesia over the back of hand, thumb and index finger. So again, here you will be having relative weakness of the thumb, because of pain, if you try to he will try to grasp something, then this is painful. So the patient will be finding it weak, like a patient will be finding it weak to hold something. So it's a relative weakness. There is no problem with any of the muscles over there, right? So this you should keep it in your mind. Okay. And if you approximately 7 to 9 centimeter above the radial styloid process, if you press, the patient is going to be jumping with pain. Okay. Then Finkelstein test is going to be positive, because as I have said that, you have a pain. So if you try to, hold your this, if your thumb is in flex your thumb, make a fist, and then try to just push the wrist into your ulnar direction, then this is going to be painful. But this is more significant of your decurvent stenosynovitis rather than superficial nerve entrapment. Okay, but the presentation is going to be same, and I'll be telling you in the end how to distinguish between various conditions, like whether it is a superficial nerve or whether it is decurvence, right? So let us discuss before that this olecranon bursitis. So olecranon bursitis, we have learned it's a bursa between your skin and the distal olecranon process. So if there is an inflammation of it, obviously the patient is going to have a boggy swelling in the posterior aspect. This will be round, fluctuating. Okay. Then elbow arthritis, it can be inflammatory, it can be because of the degeneration. So if it's an inflammatory, patient is going to have early morning stiffness. If degenerative, patient is going to have stiffness, pain, mostly, stiffness in the evening, in the morning, but lasting for less than 5 to 10 minutes. And if it is an inflammatory, it will be more than 30 minutes. Okay. The elbow movements are going to be very painful: flexion, extension, rotation, flexion, extension, pronation, and supination. And sometimes you may hear the crepitus. Okay. So all those things will be there in the elbow joint arthritis. And the most commonly involved joint is your radiocapitular joint. Fine. So with this, we have completed our elbow. So anterior, you have these conditions. You have problem with the biceps. You have problem with the bicipito radial bursa. On the medial side, you have problem with the common flexor tendon. Then you have problem with your medial collateral ligament, then cubital tunnel. If you go to the lateral side, you may have problem with your common extensor tendon, then your lateral collateral ligament, and then we have problem with the deep branch of the radial nerve. If you go to your posterior aspect, you may have problem with the olecranon bursa. Fine. So when we talk about the wrist, these are our carpal bones. We have 2 rows of carpal bones. Then you have your metacarpals and phalanx. Okay. So this is our radius and ulna, and this is our extensor retinaculum. Okay. So this extensor retinaculum, with the help of the fibrous septa, divides this whole into 6 compartments, right? So the compartment 1 has got abductor pollicis longus and extensor pollicis brevis. So we will be talking about that now. So if you have a problem in the tendon sheath of this tendon, we call it as decurvent stenosynovitis. Fine. Who all can get this? Usually who plays piano, or a lactating mother who is holding the baby with abduction of your thumb like this, the way she is holding her kid. Okay. Patient is going to have pain at the radial styloid process. Grasping is going to be very painful. Patient will say, in the morning when I get up, I try to grasp even my bed sheet, it is going to be very painful. And you can see here, when we need to grasp something like this, we need to abduct our thumb. So abductor pollicis longus abducts our thumb, and this movement is going to be painful because the tendon is inflamed. Okay. And this is the extensor. Okay, so abduction in the horizontal plane, and this is the extension. So both these things are going to be painful. And when we need to hold something like this, we need to keep our thumb, okay, in this way. So that's the reason the grasping is going to be painful, pain at the styloid process. And if you go for the Finkelstein test, which I have already described when I was talking about the superficial radial nerve entrapment. So this test is going to be, you will have a pain over the radial styloid process. Okay. And if you just look at the anatomy, the superficial radial nerve, it is there in the first compartment, okay, on the topmost side of it. So if you have the entrapment, if you put the probe, if you have an entrapment, you will be seeing the nerve which is getting enlarged, okay. And if you have a tenosynovitis, you will be able to see the accumulation of the fluid around this tendon. So you can find out just by putting the probe whether it is tenosynovitis or whether it is an entrapment. But clinically, if you want to distinguish between these two, in decurvens tenosynovitis, the patient is going to have pain at the radial styloid process. There won't be any tingling, there won't be any hyperesthesia, there won't be any tingling, numbness, but these all things will be there in case of superficial radial nerve entrapment, right? Finkelstein test is going to be positive in both the cases. So we are not going to take it as a base, but we will take the symptoms of the patient, okay? And decurvens, mostly it is here, but in case of superficial radial nerve, this may be a wider area, right? So this is how you should distinguish between these two structures, these two pathologies. So coming to the carpal tunnel is basically, again, you have the carpal bones and you have the flexor retinaculum, and which is converting this again into an osteofibrous tunnel. And beneath the flexor retinaculum, the median nerve, it passes by. Okay. So what all are the risk factors which can lead to this carpal tunnel entrapment is, one is obesity, pregnancy, diabetes, hypothyroidism, rheumatoid arthritis, and also some anatomical variants like a patient can have a persistent median artery, the patient can have a bifid median nerve, all the flexor tendons, they are passing beneath it. So you can have the inflammation of the tendon itself, which is causing the carpal tunnel syndrome. Okay. So basically, like what we have talked about, the distal bicep tendon, it is more in males. So carpal tunnel syndrome, it is more in females, middle age. Okay. Patient is going to have pain because it's a nerve. So the patient is going to have pain, tingling sensations, okay, in the median distribution of the the nerve in the palmar aspect as well as on the dorsum. You can just see in this picture that median nerve, it also supplies this top of your fingers. Okay. Basically, this carpal tunnel syndrome, it wakes you up in the night, so the patient gets up, shakes his hand, and again sleep. As I have told you in my history slide also, that when we sleep, we try to flex our, most of the time it is like this. So if the nerve is compressed, if we flex it, the nerve is going to be compressed, there'll be a local edema over there, and this is going to cause the pain. And once you shake it, it dissipates and the patient feels better. So that is the typical history the patient is going to give here. This is the Fallon test. This is how you are supposed to perform. And what we have talked, if I'm going to do like this, again, I'm trying to flex this and trying to compress the median nerve. So this is going to be positive. And if I will stretch it and I will tap on this nerve, so this is again going to be painful because the nerve is inflamed. Okay. So Tinel sign is going to be positive. Then coming to the trigger finger. Trigger finger, if you see, then I will be talking only about A1 pulley. And when your A1 pulley is involved, we call it as trigger finger. So what exactly is that? See, when we are talking about the pulley, this is the pulley. Okay, what is that? This pulley, it's a fibrous tissue. Okay. I'm sorry. So what happens? See, these are the flexor tendons. Okay, like what we have learned in the wrist compartments, that you have the extensive retinaculum like this, and then you have the septations from there. Okay, which is dividing the whole thing into compartments, so that you won't be having the bowing of the tendons. In the same way, you have the flexor tendons. You have flexor digitorum superficialis. You have flexor digitorum profundus. Okay, so when they should work, there should be like when this flexor digitorum superficialis is trying to flex my proximal phalanx, so there should be someone to hold it. Okay, otherwise what will happen? There will be a bowing of this tendon. So this pulleys, they basically hold these tendons against the bone, so that there'll be a smooth gliding of this tendon. So again, what will happen if a person who is involved in repetitively flexing the fingers, so what happens? You have the inflammation of the tendon sheath. Okay, once the tendon sheath is inflamed, the pulley will also become thickened. Then you have the changes in the tendon, and then the impingement will take place. So what will happen? That there'll be a transient locking of the flexed finger. Okay, and then when you try to pull it, there will be a painful snapping sensation. Fine. If you try to press on it, it will be tender, and sometimes if it's a long standing case, you will be able to uh, feel a nodule over there. Fine. Now, who all are the person who are at risk of developing this condition? Is again female. I don't know why, God has given so many things to females. And then diabetics, okay, rheumatoid arthritis, and people, what I have already shared with you, that people whose work or hobby requires repeated gripping. Okay. So I think that's all from my side. Now, can I take up your questions?
Hello, Kanchan. Can you hear me?
Yes, sir.
Okay, so it was excellent presentation, and I hope everybody enjoyed. At least I enjoyed a lot. So it was a superb presentation. And any questions? I asked them to put questions on the chat box, but I can't see any questions in the chat box. I don't know. Maybe your description was so nice. You have cleared all the doubts so that they can't ask any question.
Or maybe the other way around. See, if they don't have any question, let them tell, just summarize, because this is obviously the wrist and elbow. What I feel is very vast. Okay, I have just tried to concise it. The thing is that whenever any patient, any area it comes to you, what I have been telling, like, everyone, that you study the anatomy first know the structures which are present and how they are gonna present. If they are painful, what exactly will be the presentation of that structure. And many times, whatever I have told you, sometimes, I have seen a patient of one cubital tunnel syndrome, where there was an accessory enconeus muscle. So you learn, day by day, and all this, whatever I'm telling now, all this pathology is so many of the times, they are all intermingled. But if you properly know how to test that particular structure, now it becomes very, very easy to reach to a diagnosis. And most of the condition you will be able to reach to that particular diagnosis. But yes, many of times we should take the help of others, like our radiologist friend. Okay, so they can just put a probe if you are not doing it, or if you are doing it, you can just put a probe. I always say start using USG as your stethoscope, because whatever you are thinking now, it's already there. Okay, whatever, because
okay, I just wish to share the two cases. In last few days we did. Today only one case was done, very nicely diagnosed by our fellows. Ori is here with me, Lokesh is here, Saj is here. So the first case which we did the intervention today was the radial, deep branch radial, radial tunnel syndrome. But as you were telling, radial tunnel syndrome, instead of telling radial tunnel syndrome, it should be called as the deep branch entrapment. So this patient presented with the lateral elbow pain, and what was very peculiar that he was having 1.5 finger, the tingling and the pain along this 1.5 finger as well. So which we was unable to match in anyway. But he's a uncontrolled diabetic, and we thought that he's having the sometimes there is mononeuropathy, multiple mononeuropathy. So it's not only one or the heart which is getting involved, maybe the multiple nerve. So ultimately what we did was we did both the radial nerve as well as the ulnar nerve. Ulnar nerve at the Goyen canals and the radial nerve just below the radial head. So there we blocked this, and patient was having the superb pain relief. Earlier, the same patient was diagnosed by orthopedicians as a tennis elbow, because the patient was having the lateral elbow pain, and he received a sort of steroid injection there at the epicondyle. And even there is a mark, there was some, the discoloration of the that is very common in the both tennis elbow as well as the golfer's elbow, the discoloration, because it is a very superficial structure. If you're not going doing the procedure under the ultrasound to see exactly how you are giving, I have seen a lot of patients where the patient is coming up with some discolorations because the injection was done just below the skin. So this patient was have received this sort of injection and didn't have any pain relief, and we did it. Let us see, because sometimes what happens, nerve entrapment, by doing a hydrodissections or by giving some local anesthetic steroid injections, there is one of the possibility that the patient pain might be recurred. So let us see how he is doing. But today pain relief was fantastic, almost more than 80% pain relief by the patient. Another very recently, we did it probably in this Saturday on median nerve. And median nerve was again, there was a septa, and median nerve when you was doing to and fro scanning, so it saw that okay, median nerve is getting better. So these all things are possible because of the presence of the ultrasound, and these fellows are doing very nice here, and this teaching will be definitely helpful for them. Okay, one question is there. Can you repeat the pathology of the trigger finger?
Okay. So what happens in trigger finger? See, imagine this is the pulley, and this is my flexor tendon. Okay. So this is the pulley, this is the flexor tendon. So this pulley is protecting this tendon when it's gliding. This tendon, supposedly it is not there, then this tendon will bow, means it will become like this. So there is something which is not allowing it to bow. So if this is the pulley, this is the tendon, this pulley is fixing this at this area. It means like, barricades are there. When I'm traveling, somewhere, you have barricades where I have to, they are just taking care that I am not exceeding my speed. So they are just taking care that there should be a smooth gliding of this tendon. So what happens? A patient who is, see, this is true for everything. Anything, even you put salt in your food too much, you will not be able to eat. Too much of sugar, you won't be able to eat. The same way, repetitive movements of that particular, like supposedly flexor digitorum profundus, it flexes your distal phalanx. This, it flexes your superficialis, your proximal phalanx. So if something like, a person, I'm just giving you an example, a person who is just kneading the dough like this daily this much, okay, so what is happening? He is overusing it. When you overuse something, that tendon becomes, that sheath becomes inflamed. Okay, that tendon was never prepared to have so much of work. So what will happen? The sheath will become inflamed. So when sheath is inflamed, you have this much of only space. So this will start becoming thickened. Okay, because you have so you have the inflammation in the sheath, this becomes thickened. Okay, now this becomes thickened, this is inflamed, so the path becomes narrow. So the gliding movements of the tendon will not be there. Okay, so what will happen? The finger will get flexed in that particular position, and when you try to pull it, so you will have that sound. That's the reason it is called as trigger finger. Okay, I hope during weightlifting, not brachialis. why biceps is, Lokesh is asking me why the biceps brachii is injured during weight lifting and not the brachialis, which is powerhouse. Okay, so Lokesh is gonna tell me what is, when I'm weightlifting, am I extending my elbow? No, right? So what I'm doing? Oh, he is muted. See, why biceps tendon you have problem? It's because brachialis is under something. Okay, biceps tendon. Sir, you have muted me. I was talking.
Yes, yeah. No, no, please, not the whole, just middle of that.
Okay. See, the reason why the tendon it's get injured, okay, the reason is only one. When you are talking about the biceps tendon, what you have over it, okay, you don't have anything. You have skin, your subcutaneous tissue, and then your biceps tendon. So something which is more superficial is gonna get injured, right? And something which is deep, your brachialis tendon, okay, it is not that superficial, it is very deep, it is protected, and that is the reason it is not very much, what to say, it is involved, okay, in all those injuries. So biceps tendon, because of its superficial thing, it gets involved, and not the brachialis tendon because it is protected.
Okay. Okay. Thank you.
And if there is some more reason, I will just study and get back to you, because this much why tendon is involved, this is the reason which is there in most of the
Kanchan, another, this is just my thought, I'm not sure, I have not read it for any book. Another reason might be because, it is in the anterior elbow pain, it is the biceps what is always written everywhere. Another reason might be it is the anatomical structure, what you were discussing. It is the tendinous part in front of the elbow. So, not in case of the brachialis. That might be the another reason because of the anatomical structures. Maybe, I am not sure.
Is it, sir, because biceps is weak and brachialis is more powerful? So the first structure to be injured would be a weaker one.
As far as I know, this was the reason. And if there is some more thing, I will just go back, study, and I'll get back to you, because this is what I have read, that why only the biceps, because both of them, they are flexors. Okay. Flexor. But why only biceps is involved? The reason is because it is very the tendon is very much superficial. Okay. You don't have anything. You can just feel your tendon. You cannot feel the tendon of brachialis muscle. Okay. So that is one reason. If there is some other, I don't know. I will just read and I'll find out. Because
can you just repeat the hook sign? I couldn't understand the hook sign for the biceps.
Flex your elbow. You will be doing it. I'll be telling you. Flex your elbow.
So I can hook my, yes. So that's normal. Yes. So
this is normal because the tendon is intact. You are able to put your fingers beneath the tendon. But if the tendon is not there, what you will do? Nothing.
Yeah. Okay.
Any other queries from any?
So another thing is biceps tendon is attached to the radial head. And what about this the flat portion of the tendon?
That is Lesartus. That is attached to your flexor pronator complex.
So that also gets injured.
Yes. Yes. If you have a complete rupture of the tendon, obviously this portion, many of the times you will have a rupture of the tendon, but the Lesartus, that will be perfectly intact. So which portion will get, injured, I also cannot say, because many of the times both will get together, and many of the times it is only the tendon which will get hurt rather than the aponeurotic band. Okay.
So is there any difference between the action of these two tendons and this Lesartus tendon? Is there any difference?
That is just fixing it now. That is just fixing the biceps, right? It is what action? Biceps is, it is something, an aponeurotic thing which is coming from the distal tendon, and it is getting merged with the flexor pronator complex. So it is just holding that, that is the only thing, only work of it.
Thank you.
intersection syndrome and positive cracking tendon sign. Intersection syndrome. Okay. See what happens when you have two tendons, okay, which are crossing each other. So first and second, see what happens. Then you need to know the anatomy actually. So what happens? The tendon, they come like this. First compartment, they will arise from here. They will come here. Second compartment, they will come like this and they will go here. So it is intersecting between these two. So if you, it's like, you know, crossing two paths. So like if both the tendons, they are working, okay, and they're crossing their path, it means like, you know, rubbing against each other. So that's what is called as intersection syndrome. And this positive tendon cracking sign, I really don't know. Okay, so I will just read and get back to you because I really don't know. If sir knows, sir, you can share, because I really don't know.
Positive cracking sign, I don't remember. Intersection syndrome, the what you explained, it's nice, and the most important sign will be the area of tenderness. And the most important differentiating point is exactly the area of tenderness in the, it will be on the styloid process for the decoherence, and the intersection is just above, 2-3 fingers above, local tenderness there. So this is how we can differentiate between the intersection and the decoherence disease.
Basically, above that only they are crossing. This I don't know. I will just read and get back to you because I really don't know. Positive cracking tendon sign. Anything else? Okay, sir. Hari,
Okay,
I have
so
heard lots and lots of praises about you. Don't ask me from whom, huh?
Thank you, ma'am. So actually, being with sir is like learning automatically. So
yeah,
just by staying with sir in OPD, we get to learn so many things. No? Just by listening to him, we learn.
We should learn from sir. Is sir has got enormous amount of knowledge. You know, enormous. I call him Google of pain. You type anything, sir is there to answer. But if you see sir anywhere, he'll just simply keep quiet. If you ask him, then only he will answer. So he is like, in my life, I want to be like him. You know, if I can, even a 5% of sir, I would be more than happy.
No, Kanchan, it's not like that. I also don't know many things.
Sir, we call you Google of pain.
That is not possible. But what I can remember, when he was there here for 3 months, every day in the morning, day of starting, sir, I have a doubt.
I used to come
and then instead of
inside his OPD, and I'll ask, sir, I have a doubt, and sir will be, yes, ask. That was the time which I really miss. Now though it's like no one. I have to just call sir. Sir, I got stuck up. Otherwise, it was always an umbrella, You have an umbrella over you who is always protecting you, even if you do a mistake, even if your diagnosis is wrong, he's always there. So learn from him how to be very much patient, and know everything, being patient, and, what to say, focus on the diagnosis. So much. So Hari, you are lucky you are there.
Yes, ma'am.
Thank you very much.
Thank you so much.
Thank you very much, and it was really excellent presentation. And I'm sure that most participants learned a lot of things. I also learned a lot of things from your lecture. So thank you very much for a nice lecture.
Lot to me then. Okay, thank you everyone. Thank you for being there, and hope to see you soon on Friday. I think all of you are 1-year fellows, so see you soon on Friday. I'll be taking lower limb nerves. So read, because this time I'll be asking questions first and then only I'll be starting. Dr. Hari is nodding his head. Surely he will read. He's so sincere. Okay. Good night, everyone.
Okay.
Take care.
Good night, ma'am.